back. So we're going to pick up now and we're going to look at the other part of cardiac output, and we're going to look at the stroke volume and things that influence stroke volume. So again, in the previous part, we looked at factors that influence heart rate. This time we're going to look at factors that influence stroke volume. Right? So recall, stroke volume is simply the amount of blood that's ejected in a single contraction. So how much blood leaves, let's say, the left ventricle in one ventricular contraction. That's your stroke volume, right? So your stroke volume is going to be influenced by three main things. One is venous return. Venous return is simply the amount of blood coming back to the heart. Something called inotropic agent. So we talked about in the previous part something called chronotropic. Now we'll talk about something called inotropic. And then something called afterload, right? So we'll look at these three. So first thing is venous return. Venous return, again, is the amount of blood that's coming back to the heart. And this is a function of the amount of blood that leaves the heart. Right? So if you think about it, stroke volume is blood leaving the heart. That blood that leaves the heart goes out into circulation, and then eventually that blood has to return to the heart. So the more blood you eject out, so in other words, the higher, the greater the stroke volume, ultimately the greater the venous return. Right? So again, it's going to depend and determine on the amount of ventricular blood prior to contraction. Right? So again, in diastolic volume, like we talked about in the previous part, right? This venous return is influencing something called preload, right? Preload is the stretching of the heart in response to the amount of blood coming back to the heart, right? So the heart stretches as blood returns. That stretching is going to be before the heart actually begins to contract, right? So as we'll see in a moment, the heart has a good ability to regulate its force of contraction in response to blood return, in response to this venous return. So this process is called the Frank-Starling law of the heart, right? And so what it is, it's the relationship between the length of the muscle fibers and how much force the heart can generate. So how much force, how much tension the heart can generate, right? So as blood returns back to the heart, so in other words, as this EDV, so that end diastolic volume, as that goes up, it's going to stretch the heart more, so you'll have greater preload, right? As you have more stretch, you have more overlap of filaments, so those are the myofilaments, right? So that's your actin and myosin, resulting in a more forceful contraction, right? Or resulting in a more efficient contraction as a result of that more optimal amount of overlap. So the graph you see on this slide, this bottom axis is showing LVEDP. This stands for left ventricular end diastolic volume, right? So what it's end diastolic pressure. Sorry, left ventricular end diastolic pressure. So what you can see is as you increase the pressure, what happens to the stroke volume? Well, as you increase pressure, stroke volume goes up, right? As you decrease pressure, stroke volume goes down, right? So what this is it's a function of the pressure here is a function of the amount of blood coming back. So as you increase pressure, increase venous return. As you decrease pressure, decrease venous return, right? So as we have more blood coming back, you'll have more stretch, more overlap, a stronger contraction. So what happens to your stroke volume? It goes up. As the pressure goes down, which means there's less blood coming back to the heart, so there's lower venous return, you have less stretching, so less preload, less overlapping of actin and myosin. So what happens to your stroke volume? It goes down, right? So it's this idea of the heart being able to accommodate more blood coming back and less blood coming back, and keeping stroke volume roughly the same, right? Or keeping it very similar, which then causes cardiac output to stay about the same, right? So again, things that influence stroke volume, again, venous return still. If you have less blood, right, then you may have less venous return, or if you have a higher heart rate. And so this is sometimes counterintuitive. If you have a very fast heart rate, the heart actually has a decreased ability to fill with blood. So there's going to be less blood being pumped out, so a lower stroke volume, which is ultimately going to cause a smaller venous return or a lower venous return. So this goes back to the idea we mentioned previously that venous return is directly related to stroke volume, right? And again, you're getting this roughly equal output by the ventricles because of that Frank-Starling law of the heart. We'll look at another picture, another graph of the Frank-Starling law here in just a moment, right? So that's one thing, venous return. The second thing that can influence stroke volume is something called inotropic agents, right? So chronotropic, think rate. Think chronotropic agents change the heart rate, right? So how many beats per minute. Inotropic agents isn't affecting the rate, it's affecting the stroke volume. So essentially think of the force of the heart. So it causes the heart to beat more forcefully, not necessarily more quickly, right? Not as fast, right? This is affecting the contractility, the force of the contraction. And the main thing it's acting on, or inotropic agents, is acting on the amount of calcium inside the muscle cell, right? So if you have more calcium inside the cell, recall how your muscles contract, right? Your skeletal muscle, your cardiac muscle, it needs calcium to bind to the troponin, to shift that troponin-tropomyosin complex. So you expose more myosin head binding sites on the actin, so you can form more cross bridges, so you get more power strokes, so you get a more forceful contraction. So if you have more calcium, then you get more of all of those things, right? You get more, ultimately, cross bridges, more power strokes, which results in a more forceful contraction, right? So you can have positive inotropic agents, just like you had positive chronotropic, and you can have negative inotropic, just like you had negative chronotropic, right? So epinephrine, norepinephrine, those are also acting as inotropic agents as well, right? Thyroid hormone can too. A medication called digitalis, sometimes called digoxin, is a very potent inotropic agent, especially for patients who have heart failure. And then negative inotropic are those that decrease the amount of calcium, right? Which results in the exact opposite effect. So it decreases the number of cross bridges, decreases the number of power strokes, decreasing the force of the contraction, right? So this can be electrolyte imbalances, other types of blood pressure medications, so things called calcium channel blockers, which are things like amlodipine, clonidine. All of these are what are called calcium channel blockers, essentially blocking the flow of calcium into the cell, which reduces, again, number of cross bridges, power strokes, and thus the force of the contraction, right? The last kind of main thing that we'll discuss here that affects stroke volume is now something called afterload. So we mentioned preload earlier. Now we'll talk about afterload. So afterload, think of this as resistance, right? So our heart contracts, our ventricles contract, they eject blood. That blood is being ejected against some resistance, right? So imagine like you're trying to open a door, but there's something on the other side pushing the door closed, right? The thing on the other side of the door, that's the afterload, right? So our ventricles trying to eject the blood out of the heart. The thing on the other side of the door, if you will, on the other side of the ventricle, that's the afterload. So it's resistance, right? And this is the resistance in our arterial system, so in our blood vessels, right? So we'll talk about blood vessels in a later lecture, but more narrow blood vessels, so plaque lining them, longer blood vessels as well, all of those increase afterload, right? So you can imagine how if you increase afterload, if you increase the resistance, then that's likely going to affect stroke volume in a negative way, right? It's going to decrease stroke volume, which may potentially cause a decrease in cardiac output. Maybe you have a accommodation with heart rate and it goes up, so you keep cardiac output roughly the same, right? But again, size of the blood vessel, the plaque in it, the length of blood vessels as well, all of those things can influence your afterload, right? So here are some things also to consider. Again, the relationship between end-diastolic volume, end-systolic volume, and stroke volume. So again, stroke volume being the amount of blood that's ejected in a single contraction. So here you can see how venous return affects it, inotropic agents, and afterload. And then here's another illustration of the Frank-Starling law. So again, that was the relationship between the length of the muscle and the amount of force that can be generated. Again, as you increase the amount of optimal overlap, you get more optimal strength. So again, more optimal cross bridges, so better contraction. This here is showing the effect of venous return, right? So again, blood coming back to the heart, causing stretching, resulting in better overlap of your filaments, results in better cross bridges, more power strokes, increased stroke volume, right? This is your inotropic effect, right? So again, inotropic effect being the actual force of the contraction, right, as opposed to the rate, and that's largely due to changes in intracellular calcium, right? So the amount of calcium inside of our muscle cells. And then the last one that we talked about was afterload, right? Afterload. So afterload, again, that's the resistance in the peripheral vascular system, the resistance to the movement of blood out of the ventricles, right? So out of your left ventricle, out of your right ventricle, right? So again, this is just kind of a summary slide. So again, what's impacting cardiac output? It's directly related to heart rate and stroke volume. Heart rate depends on your chronotropic agents. So again, those that affect the rate, so faster or slower. And then stroke volume, again, that has to do with the amount of blood leaving, and that can be influenced by those things we talked about. So venous return, inotropic agents, and afterload as well, right? And then this is a summary slide, again, showing very similar things, just in a slightly different format. So chronotropic agents affecting heart rate, venous return, inotropic, and afterload, all affecting stroke volume. And then both of those things, heart rate and stroke volume, are resulting in a given cardiac output, right? Maybe 6 liters a minute, 5 liters, something like that, right? And then related to heart rate specifically, you can have these variations in heart rate. So bradycardia, tachycardia, this is essentially fast heart rates and slow heart rates. So slow for brady and fast for tachycardia. For these, you need to be careful to not assume that any number below 60 and any number above 100 is automatically abnormal. It could be, but not necessarily, right? And so if you have a patient who, is in the hospital, but they're an endurance athlete and they run marathons or they do triathlons, they're probably going to have a pretty low resting heart rate, right? Their resting heart rate may be in the 40s, right? In that case, that's normal, right? If you are working out, if you're a patient, if you're working in a hospital and you're caring for a patient who is extremely stressed, right? Maybe because they're in the hospital or something else going on, then they're likely to have a heart rate over 100, right? And in that case, that's probably normal, right? So take the heart rate and consider it in its context, right? Think about it in a clinical setting, right? Also think about how you need to approach treating patients with various medications who have these heart rates, right? So imagine you have a patient who they have a prescription from their doctor and they're in the hospital and they have a drug ordered that's a beta blocker, right? They have a beta blocker. What is something that you need to check before you give the beta blocker? You need to check the heart rate, right? So if you check their heart rate and their heart rate is 45, if their heart rate is 50, if it's 55, you're probably going to hold that medication, right? You're probably not going to give your beta blocker, right? So again, a big idea here is just consider these things in context, right? Consider them in a more clinical view, all right? So we are going to wrap up there, and that finishes this cardiac cycle part 3 type of lecture here. Please reach out if you have any questions, and I'll be happy to answer.